Welcome to all of you here this afternoon. It's fantastic to see such a great turnout, and welcome to everybody on webinar. My name is Cindy Triton. I'm the Director of the Research Capacity Building Program at Island Health. One of our very valued collaborators at the Canadian Institute of Substance Use Research have been collaborating with us to bring these knowledge dissemination and information dissemination sessions to bring everybody together for the last few years. We're very, very excited about this one because of the special nature of this research, because of the success it's been to date, and because of the potential for how we can move forward with this learning. So with that said, I'd like to formally open today with an acknowledgement that we are here on the traditional territories of the Lekwungen people. So it's with respect that we are thankful for this, for their customs, their traditions, and their history upon this land, and also really appreciate that we're here together to learn. So with that said, I'd like to introduce Dr. Karen Urbanoski, who is a Canada Research Chair in Addictions. She is a very active collaborator with many people in our community at many levels to generate evidence around how we can improve care and improve our knowledge and services around substance use. Karen is an assistant professor in the School of Public Health and Social Policy, and a scientist, of a great high caliber scientist too. So she works with other great scientists and other wonderful team members. She's going to tell you today, I'm giving her lots of, she's turning red here, but you deserve it all. She's going to tell you about her great team as well. So I'll sit down now, hand over to Karen and her team. Thank you.
Thanks, Cindy. And I, in turn, will introduce the co-lead for this project, Dr. Pauly, who is a nursing scholar with the Department of Nursing at UVic, and I'm Island Health Scholar in Residence and collaborator extraordinaire. This is, I have to go do the mic. Okay. This is our project team, which is fairly sizable. For this work, we collaborated with folks at the Umbrella Society and with Solid Outreach Victoria. And I guess you could say the overarching purpose of this project, where it's all going to come back to over the course of the next hour that we'll be talking, is that we wanted to develop a model of culturally safe primary care for people who use or have used substances. And so this is our collaborators. We have set up a special project area where we post materials, we post presentation slides, we post newsletters and things as we produce them. And so I've provided you with the link below there. So in the next half an hour or so, we're going to go over what we did. We'll start off with a little bit of an introduction of what is patient-oriented research. That was sort of a guiding framework that we started from. We'll talk about what is cultural safety and why we chose to work with it. It feeds into why we took the approach that we did to collecting our data and what we found. So we'll just start off with some acknowledgements. This project was made possible through a strategy for patient-oriented research grant from the Canadian Institutes of Health Research with the generous contributions of the University of Victoria, Island Health, and the Victoria Division of Family Practice. So patient-oriented research is an approach to doing research that's been gaining some some importance, some popularity, not just in North America, around the world. We've got for you here a few of the documents, logos from patient-oriented research initiatives around the world. So Involve is a patient-oriented research initiative launched out of the UK. PCORI is in the States, and here in Canada we have our very own SPORE initiative, which is a sort of a nasty acronym, but it's good. It's a good thing, and And so what patient-oriented research is all about is reorienting the research project so that the patients, the end users of the research, are involved. And I know that when I say that, I typically will have someone come up to me afterwards and say, but isn't it always kind of like that? Shouldn't it worked a different way? It's kind of like when you hear for the first time the terms evidence-based medicine, and then you wonder what was medicine before it was evidence-based, and it's a little nerve-wracking, but it actually is not something that's new, but something that's been unfolding over the past few decades, that we realize that health research of all different kinds, not just the kinds of community-based research that we do, but also many other forms of health research can benefit from having some input of the communities that are affected by the research that's being done. This is how Bernie and I have thought about this. If we could sum up what we're trying to do when we're applying a patient-oriented research or POR approach to the work that we're doing, is that it's really about shifting the power from researcher or equally clinician-driven to patient-driven research. And that's an extra layer on top of what patient-oriented research as a whole is, because that can differ a lot depending on who the investigators are and what it is that they're looking at. People can be involved in research at very different levels. Everything from having a single patient sitting on an advisory panel for a research project to simply just having the voices of patients being heard by having them share their own outcomes of the service or their own impressions of the service. There's huge variability in what people understand patient-oriented research to mean. To us, what we really tried to do was make sure that we were involving people who use substances or have used substances in helping us to figure out what we're going to study, how we're going to study it, how we're getting our data, just to make sure that we were going about answering the right questions. And I think it's important to highlight as well that patient-oriented research, just research in general, can be an empowering experience for the people who are involved in it. It can be a very positive experience. It can also be a harmful experience. And it's up to the researchers to really reflect on that. So this just sort of give you a little bit of insight into our mindset as we started this project as to where we were coming at this from. This diagram from Rosh, Gouda, and Flicker shows different models of the ways in which you can involve people, your end users of your research, in the research endeavor. So there are different, and we call those peer research models. That's just the language that has tended to be used in public health and community-based research to describe this type of research. An employment model, so you can employ people. So in our case, because we do research with people who use or have used drugs, we'd be employing people who have lived experience as a member of our research team. We could have a partner leader model where we're partnering with groups, peer-based organizations, peer support organizations, to help us lead the research, or more of an advisory role where you have a group of people that you just check in with once in a while just to kind of run your findings by them and things like that. And clearly there's a lot of room here for difficulties around tokenism, around maybe not involving people to the extent that they're able to contribute, maybe not necessarily recognizing, comes back to that shifting of the power, right? I went to school for a long time, and that gives me some training and some skills, and they're not the only skills and the only training that can be of use in the type of research I do, and so it's about recognizing that there are things that I'm not going to be able to contribute to the project that I can get elsewhere. This is our team in a nutshell. And I'm going to get back to what the core research team means, or I think actually Bernie will get back to the core research versus full project team structure later on in the talk. But for now, these are just to throw all the logos in there for you, just so you can see them all. There were so many. So we have partners at Royal Roads University. As I mentioned before, we have Solid Outreach Society and the Umbrella Society. The help of the BC Support Unit, the Division of Family Practice, and Island Health, who are all connected and helping us out with working through this project.
That was a pretty graceful handoff.
I know, right?
One of the things that the project team agreed about is that one of the fundamental issues that people face when they access primary care and they have a history or current use of substances is stigma. And just to kind of put it into context, that stigma largely comes from the way that we currently criminalize drug policy. So it's not sort of blaming individuals, providers, or organizations, but it's recognizing that when someone uses substances and our whole society criminalizes that, it's no surprise that these things get reproduced in the healthcare system. So we had identified that that was the issue, but we wanted to ask the question, how could we shift that? How could we make it safe for people to access primary care? So we looked at the history and the origins of cultural safety as a perspective in which to work. And cultural safety is a framework. It was developed by nurses in New Zealand in response to concerns related to the poor health and lack of access to health care for the Maori people who were experiencing culturally inappropriate and insensitive care. And I think many of you here will be very familiar with, the Indigenous Cultural Safety course, either through PHSA or through Island Health. And so much of that came from this initial work. But a few years ago, I was working with nurses from Insight, the supervised consumption site, and we were writing an article about their approach to care in the supervised consumption site. And one of the things that those nurses identified at that time was that individuals that they were working with, they had adopted cultural safety and the principles of cultural safety from Indigenous cultural safety, that those worked with everyone that they worked with. And so kind of with my geeky researcher hat on, I went, that's really interesting. Nobody's actually researched that. And so we did a project with Solid, where we asked the question, what would culturally safe care be in hospitals? And produced this little bulletin that has 5 principles of culturally safe care. And as you can imagine, this is such a complement to work around Indigenous cultural safety. We've co-presented with the Aboriginal Health Department several times to address issues around the stigma related to substance use. There's, in that project, we had an advisory team, and you see some members on the left of that advisory team. And we wanted to ensure that our findings were appropriately interpreted. In this project that we did now around primary care and cultural safety, we took it to a whole new level where, as Karen was showing you, Solid and Umbrella, along with our other partners, were all members of the full research team. So a couple things. These were our objectives for the project, but there's a couple of important things about cultural safety that I want to tell you specifically as to why we took this approach around particularly investigating patient understandings of cultural safety in primary care and then developing recommendations out of that. Cultural safety is highly relevant where there are concerns around demeaning, diminishing of people and their experiences when they're trying to access health care. And that's why we took it up in this context where we have substance use and experiences of substance use that get highly marginalized as well. The really important piece is that cultural safety is defined by those who are accessing care. I could probably ask many of the providers in this room, what does cultural safety mean to you, and so on, and probably what some people would tell me is, well, I think we do a pretty good job. Well, you probably do a good job as a provider, but what really matters is how is that being perceived by the person receiving care. So what it means is that actually, I'm a nurse, so it directs at me and other healthcare providers to reflect on my own power and privilege in this situation, and that's a really core tenet of cultural safety. So we really wanted to use that framework to look at how we could implement culturally safe primary care services for people who use substances. And no time more important now when we know access to healthcare is critical in the wake of an overdose emergency. Hence our approach. Karen showed you this slide already. So we had a core research team in which we collaborated with Solid and Umbrella, UVic and Royal Roads together to really define the research so that patient experiences were driving the research agenda, and we did that in collaboration and with amazing and incredible partners and support from Island Health, Division of Family Practice, and the BC Support Unit. And where it really hits the road is we can generate the findings, which you're going to see in a minute, but our partners in the whole team are critical to mobilize them, and we'll come back at the end to talk a little bit about that. So I'm going to turn it to my excellent colleagues at Solid, Paige and Grant, who've been community researchers with this project since the very beginning. And one of the things we did in a very initial meeting is we said, what would you like to see come out of this project? And that was along with the community researchers from Umbrella, Troy, Fred, and Connor. And unfortunately, we have a picture there of Connor's and Fred, because not all of them could be with us today. And so Paige and Grant are going to share with you what they expected from this project.
Okay, I'll go first. So some of the stuff just to increase awareness generally. Also dignity. Contribute in a meaningful way to the community. So just some, basic stuff there that not asking for too much.
So for increasing awareness, we hope to increase physician awareness and compassion to help reduce the stigma. We will be aware that stigma between people who use substances and primary care providers go both ways. It's not just one. And we hope that one day substance use and mental health will be less stigmatized and openly discussed. I guess one more thing on that, when the very first meetings, because we come from an abstinence-based approach and then a harm reduction approach in the same meeting, that talking about awareness and opening the door to conversation was so powerful in our little tiny room that we had to make it an expectation for the entire project, because it really helped shift our focus.
Oh, you had the clicker.
I got the clicker.
Okay. So the dignity part that we wanted to increase. Okay, so in healthcare, other social settings. Well, just gonna. I guess I'll read it all out. Okay, this in the form of more humane treatment and safe, respectful services, and we originally expected to be treated with dignity while learning and sharing our experiences with one another. Just common dignity. We also hope to build trusting relationships across the groups represented in this project. Big one, of course, was with Umbrella. We had a few different philosophies, so it was something that we learn to get along, and it is something to chuckle at because harm reduction, it's just a different approach. I freely admit I'm a active drug user, and I don't try and quit, There's times I have to quit, but mostly I just try and do that harm reduction that I don't, one of the things we were talking about this morning, I've overdosed quite a few times, especially with this whole fentanyl thing. So just staying alive, for me is, kind of important. And so harm reduction is my goal. I might want abstinence one day, but that's not really what I'm seeking. And I think Fred and others might have a different approach. Might have, but we got along pretty good. That was the overall happy ending, that we really were able to work together well.
There's a mutual expectation.
Mm-hmm. Yeah, so that was something right from the beginning that we identified.
The third one is to contribute in a meaningful way to the community. And a big reason that this was important for us was because as drug addicts, whether former or current, we've mostly just taken from the system and from the community. We're either born into it, or we get reinstitutionalized, or just put in the system. We're constantly taking from the medical system, going into ERs. Like, we're just a burden on society, and we really feel that to our cores. And so to be able to be involved in research that contributes back to the community, and it gives back to our friends, our family, the people around us, and the people that support us, it was such a big deal for us. And for everyone who participated, because as we were getting participants, they were just so thrilled to be asked the question, and then to know that we had a full table of people who were actually listening to the answers. We also expect, so I've commented on both abstinence and harm reduction models, and how it was important for, we took what we've learned in the past from Insight and what we're learning right now in the crisis, and we're trying to apply it, because we know it probably won't affect current drug users and how we're being treated, but most of us are family, or we do have family, and it is generational. So we want a better system for our family and our children and our community members
in the future. Yeah.
That's it.
Okay.
So Fred, let's now follow that up by telling them about concept mapping.
Okay.
Yeah.
I think you can open.
Really, really interesting. Yeah. You want to start?
Me?
Yeah,
Oh.
Go for it.
Okay. So we kind of broke down the project into three focus groups. We started out, we had 75 people who had committed to take part in the project. And the first one, we just brainstormed ideas. So we had a total of 700, what's the number?
We ended up with 700 statements. So I'll put this up. You want to tell them the focal prompt?
The what?
Um,
Oh, okay. Okay, sorry. We started out with the statement, I would feel safe going to see the doctor if. And the participants took part in the brainstorming session, and we had roughly 3 pages of notes in point form from each group, and it all resulted in a total of 700 statements. So then the second group, we sat down again to review, between that, we had to then condense those statements, and we had so many duplicates. And that was the hardest part by far, I think, of the project. We initially tried to sit as a group with all of us in one room, and there were 3 conversations going on simultaneously. And I had to keep, my fists were clenched. I'm amazed that I made it through that. I think I made $50. That was probably took 5 years off my life. So for the next meeting, we actually broke into 2 separate groups, and then we communicated by phone to get approval. And we probably tripled our productivity. So if anyone is wondering, 3 is the right number of people when having a discussion of this nature. So
the third time that we met with our participants, We had them, or I guess the second time we had them meet and get together, they sorted the statements that that we got from the first round. So in the first round, we have them all brainstorm what, finishing the sentence, I would feel safe going to the doctor if. And we record all those. We go through the crazy process that that Fred just talked about of getting them down. We got them down to 73 statements that we figured probably weren't duplicated. Wanted to get it down enough so that people could sort the statements into groups, but not lose the meaning of what we were hearing, right? So it's a balance. And we had them sort 73 statements into piles based on conceptual similarity with each other. And then we met the final time to talk about what they would call the different clusters of statements and how important all of these different 73 ideas were to the idea of cultural safety. That's the money photo there. It's the best photo. So as Fred mentioned, we had 75 participants over 12 focus groups. Seriously, within 3 weeks, it was we were seeing each other every day, which might have also taken some years of Fred's life. I'm not really sure. You guys led the groups. Yeah, we were there, just in case. We were mindful of getting a mix of people, right? And I think we were mindful of making sure that we got both men and women. I think some of the groups were only women.
That's correct, yeah.
Yeah. So you guys really went off, and because of Connor, we ended up getting a nice group of like 24-year-olds, like 24-year-old hipsters specifically. Which was great, and we had really high returns. So we had about 80% of people came back for the second round, the third round, which as a researcher is pretty fantastic. I'm impressed because I don't get that kind of response rate. I think that was due to you guys. I don't know what you guys did to make them come back, but hope it wasn't illegal. Okay, so yes, mind-melting experience, that's what we called it. So I think we all felt that. I think what I learned from reducing those statements down was that we needed to think about how fast we were moving, the pacing of the meetings, listening to the differences in perspectives, because we understood the statements differently, didn't we, depending on who we were.
And a lot of them, it was like splitting hairs, slight change in wording. And then when we looked back at them, we realized they were completely different statements. So, their review was definitely required. And again, with splitting it to the smaller groups, that actually gave the chance for an actual conversation to take place. So
yeah,
that was
good.
Very difficult, but it worked out well.
I remember one statement was, I want a secluded place to receive my pain meds. And I had that. I was trying to collapse that with a confidentiality issue until one of you guys, and I'm not sure which one it was, said, no, it's safety, because if I'm handed a prescription for opioids or I'm getting it in a pharmacy in front of everybody, then I'm going to get jumped when I leave. And that wasn't something I really thought about. And so it was how knowing the participants, which you guys did, because you recruited all from your own networks, made a difference, because you remembered when you saw the statements, you remembered who said it, and it was like, well, I know what they were talking about there. It's not what you think. This is what the core idea was. So that was very helpful as well. Because as Bernie said, it's not my idea of cultural safety that matters. All right.
This is pretty smooth, actually, having 5 people present, so I hope you're enjoying the set changes. This was going to be Jack, Paige, and Grant, so for those of you that know Jack, I'm stepping in for Jack.
And she's pretty excited.
So after all of those statements were sorted, like people literally had cards, put them into piles, Dakota, our amazing research assistant, took all of that, put it into a computer program called Concept Systems that uses, and this is just like the technical part, it uses multidimensional scaling to put together statements that people most often sorted together, right? And so then our core research team looked at multiple groupings from like 15 groupings all the way down to about 6 groupings. And we went back and forth because each grouping has a set of statements with it to decide what was the right number of groupings that would best represent what people in the project said was culturally safe care. So we ended up with these 8 different colored clusters. So this is what a concept map looks like. And attached to each of these clusters is obviously a title, a definition, and a list of about 10 to 12 statements. So there's a lot of information there about what cultural safety is. What we're going to do today is Paige and Grant are just going to go back and forth and share with you each of the clusters and give you the definition.
Okay, and then I got the clicker now.
You're in charge.
Okay, first one. Don't red flag me. Recognize addiction as a health issue. So the definition is physician is drug-wise, meaning that they're knowledgeable about and recognize addiction as a health condition, not as a criminal issue. And they are up to date on treatment, management, and resources. The red flagging, don't red flag me for my drug use and instead offer a range of treatment options, including harm reduction. I don't know if everyone knows the red flag concept about, if you're purple dot. Some of you might recognize it as that way. Is once you're identified, you're it's there for years and years. So that didn't seem right. So that's one thing we gotta acknowledge.
From both groups.
That we wanted to address.
Act to prevent stigma. Don't treat me like crap. The care I receive is characterized by respect, dignity, sensitivity, empathy, and understanding. I'm not fearful of being judged, labeled, or stigmatized for drug use. And we were it sounds really basic, right? Respect, dignity, sensitivity, empathy, understanding. Everyone thinks they're that way, especially probably if you're in healthcare, because that's why we care about people. But how do you view stigma? Is it a positive tool? Or do you see the harmful effects of it too? Do you have a full range, and do you have options? Are you presented with all of the options? Because everyone's an individual.
Hey, I'm human. Treat me right. That was mine. I'm a human being. I use drugs, but I'm still human. Don't turn me away or refuse to provide care for me as a result of my drug use. Treat all patients with respect, compassion, dignity, and human decency. It's not asking too much. I guess one of the things that some of us, experienced a lot of, being turned away. And just that's all we're asking. It's kind of self-explanatory, but it's very important.
Live up to professional standards. Live up to professional standards. So the doctor has up-to-date knowledge of addiction and pain management for people who use drugs. My doctor collaborates and communicates with me to make informed decisions about my treatment, especially in regards to pain medications and pain management.
Do you care about me? Do you care about me? The definition, feeling like the physician has time and isn't rushing. We have a relationship and rapport with consistency in care from one provider, which allows for continuity and follow-up. Our relationship is characterized by trust and rapport, and the care provided is holistic. It's wishful thinking in some cases, but that's what we're looking. That's what we're looking for, right? Yeah.
Main maintain my confidentiality and welcoming in a welcoming and comfortable environment. The environment of the clinic itself is welcoming, comfortable, and non-institutional to reduce my feelings of vulnerability. The room has to have adequate space. Office policies and protocols are often designed to ensure patient information is kept private and confidential. There is no public way of sharing information in the waiting room between staff. I don't have to wait for an appointment, and information are accessible. This was just all around, almost in every single statement. In almost every statement, just because the number one reason for people not wanting to go to the doctor is from bad experiences in the waiting room. Having the nurse say, "Are you here for your STD testing? Are you here for your HIV medications? Are you here to see so and so?" And because they're used to saying it so many times a day, they don't even, and they know, I know Grant and Fred and everyone in the room, so they just assume that everyone knows I have HIV. Well, no, none of them did, but now they all do, thanks. And so that's just a common theme that we've heard come up as an example.
Yeah, right across the room. Hey, HIV meds, that should be 8. And, no, one more. Acknowledge and accommodate my needs and circumstances. Definition: an approach to care that recognizes the social determinants of health. It makes the necessary arrangements to ensure care is not limited by my circumstances. Patients should not suffer negative repercussions and harms as a result of their social and economic position in society. I don't know, anything you want to comment on that? That's kind of self-explanatory. Yeah, that's good. Take it away. I thought that's enough.
Yes, this is the last one, and it was be a champion for advocacy. And even though it's really a small, funny shape, it was the hardest name, even though it had the least amount of statements to it. I don't know. You'd think like a bigger cluster might have a harder time because there's so many interpretations, but this little one created the. It just took a while to get, and once we got it, we seemed to understand it better. Patients need support to feel safe and secure to reduce anxiety that they have about seeking care. These supports extend beyond the competencies and characteristics of individual physicians or the clinic itself to include environmental support such as an advocate, the environment outside the clinic, and the system support such as adequate insurance coverage. A lot of times it has nothing to do with you. It has nothing to do with the clinic. So, sometimes it's just about having a support person there, and the support person isn't there to judge you or make judgments on the situation, but rather just to make someone feel comfortable so that you can have that open and honest relationship. And then once that's established, we hope that will carry through.
Okay.
So while we were going about collecting this data and putting together this model and trying to figure out what it all meant, we were also meeting regularly with our full project team, which included physicians from the Division of Family Practice, as well as representatives from Island Health, the BC Support Unit. And we'd get together regularly and we'd talk about cultural safety and research, for one, as well as primary care. We'd share what we're learning and get feedback on how we were interpreting things, and do some planning around knowledge translation. So what are we going to do with these results now that we've got them? And this is really the fun part. I'll just say that we purposefully chose, we chose to apply for a strategy for patient-oriented research grant for this project. It means this was a patient-oriented research project. It was a community-based participatory project. It was done purposefully so that we would be working with people from the community very closely, helping us lead this project. We also chose to work with the concept of cultural safety, which meant, as Bernie talked about earlier, that cultural safety is defined from the perspective of the folks who receive the care, not based on the actions or the understandings of professional standards on the part of the people who are delivering the care. And we all know We all knew when we started that this was going to be hard. And I know, because I know some of you, I know we do have some physicians in the audience, this is not about physician bashing, about blaming physicians for being this or that or the other. This is about starting a dialogue with healthcare providers of different kinds about understanding the perspectives of each other so that we can move forward. We know there are contextual reasons and systemic reasons that account for a lot of things like time, the time that people have to spend with patients, the fact that you have to see someone every 15 minutes, the fact that now you've got opioid prescribing monitoring, and there are a lot of things that you need to know and things that you need to do in order to run the practices. Not everything that we heard from everybody came from negative experiences. We did hear a lot of very, very negative experiences. We heard some things that were done to people that was illegal. Of course, in any profession, there are people who are good at their jobs, and there are people who are not. But that said, we also heard from people about, man, do they ever have tough jobs, those doctors. And I wouldn't have wanted to be them when I was coming in, and I couldn't communicate to them what was wrong, and I couldn't tell them what was wrong for whatever reason. I know I'm difficult to deal with. Maybe I did very well, and I had an excellent experience with a physician. I know what cultural safety is in a primary care office because I have that with my current physician, and they shared those experiences too. And so what we really want to do with this project now is, of course, start working with physicians on how to implement some of these. How do you interpret some of these cluster names? How will you work with these topics and these concepts? What do you need? Are there products that we can make for you that share these findings that you can use as leverage to tackle some of these big systemic issues that prevent you from being able to deliver the care that you want to be able to deliver to marginalized populations? And so if anybody does want to come and talk to me about this or engage in a dialogue with me about this, absolutely you know where to reach me. You can reach Bernie, and we'll talk a little bit more about what we've got so far in terms of a plan for knowledge exchange, which is the phase that we're engaged at now. For instance, doing this talk. For one. So we came up with some objectives of the things that we want to do in sharing these results. We want to raise awareness of the issues related to stigma and barriers to primary care experienced by people who use or use substances and share understanding of cultural safety for this population. That's why we came up with the model. Stigma in primary care was the one issue that I think in our early meetings, when Solid and Umbrella, as we were all together around the table, initially that was the one topic that we could all agree on was something we needed to discuss. And the Victoria Division of Family Practice was on board, Island Health was on board. This was the one topic. Everybody had personal experiences with that they really wanted to kind of unpack and think about. Another goal of our knowledge exchange plan for this project is to support the ability of people who use or used substances to advocate for their own primary care. And so one of the great things that we produced was a postcard. There are some at the front. Bernie's got one there, and you're welcome to pick one up or let us know about it. We've got lots to hand out. Just give some people something that they can take with them to the doctor to start a dialogue. And a lot of those, we know, a lot of those clusters, they describe stuff that everybody wants, right? These living up to professional standards isn't a criticism or a dig. It's just that's an expectation. I expect that when I go to the doctor. That's just a thing. But maybe it'll start a dialogue, right, about what that actually means. Number 3, we want to secure the commitment of people who use or use substances, physicians, health planners, government, to collaborate on strategies to improve cultural safety in primary care. And we want to encourage the same groups of people to help us develop and implement policies and practices that are going to do that. There's our postcard, designed by our very own Dakota Inglis, coordinator extraordinaire. The 8 statement clusters are on the back, so it's a 2-sided postcard.
I think the piece that's important about this project, it's not that primary care is the site of stigma. we work in a society, we work in a healthcare system that's highly stigmatized. We had a chance to do work in one area. And a really important follow-up to this project, Elizabeth Hartney from Royal Roads University led the submission to Michael Smith to get a grant, and working with Bryn as well, who's here. She can tell you more about the next phases of this, but we basically got the grant to be able to bring together people, the community researchers from this project who've been involved in creating this, who sat in all the focus groups, who facilitated all the focus groups, to bring them together to share these findings with physicians in the divisions of family practice. And that's, from a research perspective, that's amazing that we're able to bring those groups together. And I don't think we could have done it without Island Health, and particularly without Cindy Triton, who's research and capacity building lead. She brought us, this project, she brought us together at the beginning because of her own, knowing all of us and our passions brought us together. And now we have this opportunity to actually, and we've had some initial discussions about this, but to actually say, how would physicians in primary care actually take this up? What would they do differently? Would it be something in terms of guidelines, education, and so on? And so that's a really important next phase of the project. However, this was a research project as well, and because we didn't have enough to do with 800 statements and analyzing them and doing focus groups, I can't tell you, when Paige said to me that we were going to do our focus groups in a week and a half, I just like died inside, because I was like, there's no way I could ever do that. But of course we did it, because we worked in the same, you know, I know on with Karen and Umbrella did it so fast. But what we also did is we asked ourselves, what would make this culturally safe research? So we had a little side project where we did focus groups with ourselves and asked ourselves what would make it culturally safe, because we were embarking into a territory of doing patient-oriented research in which the potential for stigma and discrimination also exists. And if you sort of follow the patient-oriented research movement, one of the criticisms of it is we typically tend to engage white middle-class people as patients. We don't engage a diverse range of people. So what we did is we came up with this definition of culturally safe research must be led by people with lived experience of substance use, past or current. They determine what is safe within a collaborative and a community engaged framework. Lived experience is valued, and recognition of how stigma and power operate with equitable process for doing research and action as an outcome. And I think the action piece is what really came home to me. We couldn't just do this research. We couldn't just write a paper. We had to do action. So that's the phase we're in now. And we would love to turn it over to all of you to ask us, maybe we could, all the team could come up and we could see what there are questions. We have, I think, at least 10 minutes. Yeah, about a little more than 10 minutes. And thank you to all of our amazing team.